So thank you very much for being here today. It's always good to be in a packed room with people standing at the back. And it's great to see that there's still so much energy for the renal denervation space. My name's Rasha Alami. I work at Imperial College in London. It's my absolute pleasure to be here with a fantastic panel who I'll introduce to you in a second. We're here to hopefully have a very interactive session in which we can all go through the various indications for renal denervation, some of the evidence, and also some of our clinical practice. You can see that there are mics around the room. Feel free to stand up at the mics and ask questions, and also to ask your questions on the app, because we'll be watching as we go through. So this is a session that's about clinical practice and also some of that evidence. And what's important to think about is that hypertension in of itself is still a major contributor to cardiovascular disease. In fact, the primary contributor to cardiovascular disease around the world. And we forget it very often, and we're not very good at thinking about optimizing our patients' blood pressure control when they come to us in clinic. And our primary care physicians are also not so fantastic at doing this. And so today, Medtronic are helping to sponsor, as part of the May Measurement Month and a big kind of effort to have more and more funding within that hypertension space, they are going to match, they're going to donate lots of money based on all of you guys taking your phones now, taking a snapshot of that QR code. And once you go on that QR code and you force the Medtronic team to spend lots of money on our patients. So I want to see all of you doing that immediately. And as you can see, if you comment, they have to treble their share. So please make comments. It's always good to squeeze industry, and this is your moment. Okay, so hopefully we've got that going round. Perfect. So it's my pleasure to be here today with a fantastic faculty. So my co-chair is Marcus Schlack, who will be there to take your questions, obviously introduce our panel, and help to moderate our discussion. Felix Mahfoud will be here to talk to you about his experience with renal denervation. Also, Valerie Duchatel and Flavia Riboccini. So a fantastic panel. We're ready to answer any question, and no question is too hard. So importantly, we need to think about what we're doing here. We know the principles of RDN, that it disrupts the afferent and efferent neural communication between the kidney and the brain, and that there have obviously been lots and lots of sham or placebo-controlled trials in this space now that have shown that this device really does work, and there's a real evidence base that's beyond most of the evidence base that we have out there in interventional cardiology. And in fact, that over 30,000 patients worldwide have been treated with the Symplicity system. So we've got an evidence base. We know that it works in our patients, but the real question is, why are we not using it more? What can we do to roll this out into clinical pathways? And we're going to have lots of that discussion today. So without any further ado, I'm going to hand over to Felix Mahfoud, who's going to talk to us about the European guidelines and where we are now with renal denervation.
Thank you, Rasha. Good afternoon. It's great to see a packed room. What I'm going to discuss with you is the most current guidelines on hypertension management and where we stand with renal denervation in these documents. We live in a crazy world, obviously. We also live in a world where we have two European guidelines. Very unfortunately, I would say for political reasons, the two major societies dealing with hypertension have decided to separate and are providing two distinct guidelines, one published back in 2023 by the European Society of Hypertension and one published in 2024 by the ESC. I would say 90–95% of the documents and the recommendations are similar, are aligning. There are a few differences, but fortunately, when it comes to renal denervation, the two guidelines are quite similar, I would say. So first, very importantly, the class 3 recommendation that we provided back in 2018 has been removed. So there is an escalation in the class of recommendation where you now see that it's no longer red, it's indeed turned into a class 2 recommendation. And the ESH guideline would state that in patients with preserved renal function, defined as an eGFR above 40 mL per minute, and those who have uncontrolled hypertension, despite the use of antihypertensive therapy without any numbers or minimal numbers being provided, or if drug elicits serious side effects, one may consider renal denervation in our patients. And secondly, we should consider renal denervation as a treatment option in patients with resistant hypertension, so on multiple medication, typically 3 or more, including a diuretic. And again, this is also a class 2 recommendation. There are class 1 recommendations referring to renal denervation. I think they make a lot of sense, and it was quite clear during the guideline writing that we agreed on a shared decision-making process. We're understanding that renal denervation as an adjunct therapy to lower blood pressure has to be discussed with our patients, and in a shared decision-making, we have to agree that this is the way to proceed. In many options, in many patients, it's another option, another approach to lower blood pressure. And you are in part experienced, or you're gaining your experience with renal denervation, which is great. There's some learning curve with this technology. So indeed, the guidelines would also recommend that only trained interventionalists and experienced centers who are capable of taking care of patients with difficult to control hypertension should consider renal denervation in their appropriate and carefully selected patients. I like this flowchart very much because it's quite simple. You can see here the recommendation by the ESH guidelines, where you can see on the left-hand side patients with an eGFR above 30 mL per minute, treated with 3 drugs containing typically the first 9 agents, ACE inhibitor, ARB, CCB, or diuretic. If you're unable to bring patients to target blood pressure values to control patients, then you have the option to either, this is not an AND connection, it's an OR connection. So add spironolactone or an alpha blocker or a centrally acting sympathetic, or consider renal denervation. So it's not intended to be an escalation, right? You don't have to try spironolactone in all your patients before you consider renal denervation. The guidelines would allow you to do that as soon as you have escalated therapy to 2 or 3 drugs. If the patients tolerate those drugs, then consider denervation in a shared decision-making process. The ESC is similar on many aspects. They have a different language here. You can see a class 2 recommendation for renal denervation in patients who have resistant hypertension, so 3 drugs or more, who express a preference to be treated with renal denervation. And if you consider denervation in patients with fewer than 3 drugs, then the cardiovascular risk of those patients should be high. And this is given the risk-benefit ratio of an invasive procedure, although we haven't seen any serious adverse events being associated with denervation. The guidelines committee felt here that you have to balance the risk and benefit to patients. And in those who have a high baseline cardiovascular risk, then you can consider renal denervation as well. They provide class 3 recommendations too. So as with traffic light, we should not pass that. It's not considered as a first-line therapy. I guess that's in most circumstances not being ever considered, that denervation would replace antihypertensive drugs, but it's an add-on and adjunct therapy, as mentioned before, and the guidelines would also say that you should not use denervation because of the lack of randomized controlled trial data in patients with an eGFR below 40 mL per minute. Is that really that strict? I think we have good reasons to believe, but require more trial data to support the use of denervation also in patients with lower eGFR cutoffs. This is data from the GSR, the Global Symplicity Registry, looking into patients with an eGFR below 45 mL per minute. And you can see here that irrespective of whether patients have an impaired or a preserved renal function, the blood pressure change is pretty much the same, as is the number of antihypertensive drugs, again, not explaining the reduction in blood pressure. And eGFR remains stable following denervation. That's a very clear signal, and we're obtaining that from various analyses. The larger the data set gets, the more robust is the signal that indeed denervation has no negative, no deleterious effect on renal function over time. Do we have any data to support the recommendation by the guidelines, or what happens if we would apply the guideline recommendations to patients who underwent renal denervation? This is something we have run in a dedicated analysis looking into the global Symplicity registry, again, the largest registry of its kind, with more than 4,000 patients included. And for this analysis, we looked into patients where the guidelines would recommend renal denervation. You can see that this is the majority of all patients in GSR. So the guidelines have already been applied, obviously, in the past to some extent. Patients who fulfill the criteria, again, meeting the blood pressure cutoff, 140, systolic, diastolic of 90, taking 3 drugs or more. And if they had fewer than 3 drugs, we checked their cardiovascular risk and their comorbidity profile. And those who fulfilled the criteria of having high cardiovascular risk, we looked into the outcomes. And this is the overall cohort where you can see through 3 years of follow-up a significant reduction of a systolic blood pressure by 16 millimeters of mercury. If you look into patients who would fulfill the ESC guideline recommendation, the blood pressure reduction is even more amplified, 20.5 millimeters of mercury through 3 years of follow-up in that particular cohort. So when applying the criteria, the recommendations by the guidelines, we shouldn't fear that the outcomes are different to what we have seen in patients in the global Symplicity registry. The percentage of patients with blood pressure below 140 was significantly increased by 40% or to 40%. 40% of the cohort, almost 40% of the cohort, had through 3 years of follow-up of a systolic blood pressure of below 140. And again, an escalation in pharmacotherapy is not explaining the outcomes here. If anything, there is a numerically reduction observed that is statistically significant, but of course not clinically meaningful, and definitely not explaining the reductions in blood pressure. Another important aspect is when it comes to shared decision-making, and this is my last slide, highlighting an outcome that we have seen now in various trials, randomized controlled trials, observational data, and registries, and that is the fact that after the steep reduction in blood pressure, we do see a sustained and progressive reduction in blood pressure. At 3 years, 18 millimeters of mercury, that is the change in blood pressure observed in this analysis comprising 4,155 patients. So when shared decision-making is being applied and discussed with patients, then we should talk about the right numbers, and this is what I'm using my patients. Roughly 15 to 20 millimeters of mercury is what we should expect in our patients undergoing the procedure. With this slide, I will summarize and conclude my talk, stating that the two European guidelines have escalated their level of recommendation in terms of with respect to renal denervation. Both provide a class 2 recommendation that renal denervation may be used in patients with resistant hypertension or those who are difficult to control on fewer drugs, and in particular who have high cardiovascular risk. With that, I'd like to thank you very much for listening, and I look forward to your questions now.
Felix, thank you so much for this very important talk. What a milestone it was to see that renal denervation is now mentioned in guidelines. It took some time, but I think it gives us all confidence that the evidence is certainly strong enough for this to be recommended. My name is Marcus Schleich. I'm from Perth, Australia, and just want to say a big thank you to Medtronic on this occasion. I'm on the management board of the May Measurement Month, which is a global blood pressure screening and measurement campaign. Over the last 5-6 years, they screened 7.5 million people and identified, of course, a lot of them with blood pressure. So again, would encourage you to use your phones and tick in, we need more support. Now, moving forward with the program, we will have time to ask questions to Felix and Valerie as well. I would like to introduce Valerie Duchatel, who will now talk about tips and tricks ensuring a successful spiral renal denervation procedure. And we will have some discussion time right after. So keep your questions until Valerie's presentation has been done. Thank you so much, Valerie. All yours.
Thank you for the introduction. Hi, everyone. It's my pleasure to be here today. I'm going to share a very specific talk about how to do the procedure, and hopefully in a few minutes you'll feel very comfortable with starting your first case. my disclosures. So the Medtronic system is called the Symplicity for a reason. It's very simple to use. So it comes with a catheter called Spyral, and it connects to a G3 generator. The catheter is something we're used to in the cath lab. It's a very simple over-the-wire system. It fits the standard 0.014 guide wires and is compatible with the 6 French guide catheters. It's easy to use. You just have to plug it, and then the machine is automated. The way the energy is delivered is automated, as I've said, and the algorithm will provide feedback and adjust automatically to provide adequate temperature rise. And the design of the catheter is helical, so it will cover all 4 quadrants of the artery for a circumferential ablation in just one shot. And this is extremely important. We need to take a moment to look again at the anatomy. So here we have the main branch of the renal artery and then the 2 secondary branches. And most of the nerves that we're targeting will not be within 3 millimeters of the lumen until they reach the bifurcation. So if you just treat the main branch, you will not achieve successful procedural rates in most of your patients. As in the main branch, only 46% of the nerves will be within 3 millimeters. So you need to cover both sides. And on both sides, the main branch and the bifurcation branches. By doing that, if you look on the right-hand side, those are the norepinephrine renal concentrations after treating just the main, the secondary branches, or both. And you can see that the drop in epinephrine is much higher when you treat both. A quick word about patient selection. You should review the indication and the objective with your patient. Get written consent as always. And something I like to discuss with them is the kind of sedation they would like. Some centers still do it with general anesthesia. It's not necessary. It could be useful for your first case if you're nervous, but with sedation given by an anesthesiology nurse, an MD if you have access to them, or just bolus fentanyl, that's plenty to cover stress and pain management. Something else we like to use, we use it also as the secondary hypertension workup to rule out renal stenosis, is an angio-CT of the renal arteries. It's not mandatory, but if you get it when you do your secondary workup, then you get a very precise view of the anatomy, and it will tell you if you have some accessory renal branches that you need to treat, as these are very well innerved and they will enhance your procedural success. The setup is the classic cath lab setup with the patient laying on the table. There's an electrode you need to stick to their left leg. And if your patient has CKD, you may want to dilute the iodinated contrast agent. You can do this even with the injector pump up to a dilution of almost half and half, 60 contrast, 40 of saline. And this way, you still get very good quality images. A tool we recently started using is the virtual reality hypnosis mask. Especially if the anesthesiologist is busy and can't give you a head, your patient will be traveling to Antarctica on the beach as you perform the procedure, and they respond to pain management much better. When it comes to the access, we have to go through the common femoral artery. I highly recommend you can use an ultrasound-guided puncture to reduce the complication risk. It's been done through the left radial in short patients, mostly in Asia, but it is not the route where you should start. This should really be like a bailout option if your patient is short, severely obese, or has no femoral access. You will start with procedure. You could see here with an angiogram. This step is mandatory if you do not have a pre-interventional CT. And then you can choose, given the entrance of the artery, if you want to have a 90-degree takeoff, you can use RDC or GR4. If it's descending an IMA, you may also sometimes use a multipurpose. So basically, all your regular guiding catheters. Now, what you want to target when you do this angio, you can see the shadow of the kidney. I have made a very beautiful circle in red. It's not my 5-year-old, that was me. And then all the green dots are what you want to target. So everything above 3 millimeter and between 3 and 8 max diameter, at least 5 millimeters away from the renal parenchyma. So it looks like there's a lot of dot, but remember you're doing 4 at a time, so it's not that many ablations in the end. Once you unpack the catheter, you just need to plug it, and then if you want to deactivate some electrodes on the remote, that's very easy to do. The rest is standard as in a PCI. You give heparin to achieve an ACT over 250. You would give a little bit of nitrates in the artery to prevent spasm, and then you're going to wire the artery and travel with your catheter. Remember to bolus the painkiller a few minutes prior to the first ablation. Now the energy delivery, all we have to do is push a button and make sure, as you see here, that the wire is pulled back and within the spiral catheter when you deliver the energy. The machine will let you know if the ablation is successful or not. If it stops before 45 seconds, you need to consider redoing that point. If it's 45 seconds all the way to 60, no worries, you can move on. Now, a lot of renal arteries are extremely tortuous. The good news is the catheter tracks really well. It's like a PCI balloon. It tracks extremely well, especially if you're using an extra support wire. So I now use the Sion Blue extra support wire as like my workhorse wire for all RDNs. And with that, the use of extension catheter, like a telescope or guideliner or whatever you're normally using, is not so common. Some other useful tips, especially at the beginning of the procedure, when the patient is anxious, he might breathe in deeply, and then to help stabilize the catheter against the wall, you want to torque 90 degrees clockwise or counterclock. This also happens when they're fully sedated and they start snoring and sleeping deeply. So this is a useful tip. The other tip I have developed over time is in the smaller distal branches, if you activate all 4 electrodes, the temperature might rise too much and the ablation could fail. So in those distal branches, if you get that message, just deactivate 2 or 3 electrodes and perform ablations one by one, and you'll have success. After the procedure, we do a final angiogram to confirm there are no complications. You can see some teeny tiny notches here and there. This is just confirmation that there has been an ablation on the wall. You can give nitrates if you see spasm, and then you use your usual closing device, AngioSeal or Perclose, whatever you're normally using for your femoral arteries. Monitor the patient for at least 6 hours. In the clinical studies, you will find that the patients have been receiving aspirin for 1 month, but this is not mandatory, so you can evaluate that given the bleeding risk of your patient. And when it comes to the results of the RDN, it's probably better to wait for 6 months before you do an ambulatory blood pressure measurements, as some patients take a bit longer than 3 months to respond. So in summary, the catheter will fit all vessels between 3 and 8 millimeters. It's compatible with your normal 6 French guiding catheters. You do 4 points to cover the artery circumferentially. Remember to always do on both sides main and distal branches. All your PCI tips and tricks will work to bring the catheter when you need to bring it. And pain and stress managements are absolutely no problem to this day. I hope I've given you some helpful tips, and I'll be very happy to answer some questions.
Okay.
Thank you very much, Valerie. And this is something we should aspire to, go to Switzerland and hike some mountains, which sounds great. We now have around 10 minutes for questions, ideally suited for the 2 presentations we heard. I would encourage you to use the phone, perhaps briefly introduce yourself and have relatively short questions. Please make use of the microphone. While we're waiting for the first people to come up, Valerie, I know you also see quite a number of patients with hypertension yourself. In the context of considering renal denervation, what is kind of from a clinical perspective your guidance? When do you think about renal denervation, and when do you start a discussion with one of your patients whether or not that's something to consider?
Well, I think patients who are suffering from severe blood pressure drops and are symptomatic are the ones that are going to adhere the less on the long term on their treatments. And these are actually very good responders and even earlier responders than those with resistant hypertension in our experience. So I don't think they should ditch their medication right away, but it's definitely a useful tool in that setting, because if you discourage the patient from taking medication, their adherence will drop over time, and they will be harder and harder to treat, and probably they won't come back to the clinic if not being listened to. So we're always scared of the higher numbers. Your blood pressure is 160, so we keep increasing the meds. But what the patients feel most of the times are the side effects from the heavy blood pressure drops in the afternoon, and of course the consequences that can lead to. If you're still an active worker and you have to take a rest, if you're an older person and you break your leg and so on.
Thank you so much. We've got a question from the audience. If you introduce yourself.
My name is Dr. Bikash Majumdar. I'm from India. I have one question. Before taking up a patient for RDN, what are the routine tests you will do in order to rule out any secondary cause of hypertension?
So the workup will be that recommended in the guidelines for secondary hypertension. So the minimal to rule out would be the renal artery stenosis. And also because if you're planning a procedure, you want to see the anatomy, you need to rule out pheochromocytoma, as those have a specific treatment, hyperaldosteronism. And then there might be aggravating factor like heavy alcohol consumption, salt consumptions. Those are not contraindications. They're more like factors that you also need to work on to ensure better success.
So do you routinely do these tests before taking up?
Yes. So they come to the clinic, we do all the tests, and then we have a discussion, and we bring the results to the patient, and we try to offer the best compromise, which is generally the procedure, but also dietary, exercise, lifestyle recommendations too.
It's perhaps a good opportunity when you consider renal denervation to actually, again, actively screen for secondary causes. It's not mandatory, but obviously it makes sense. And we do know if we can target the pathophysiology accordingly, we have more chances of improving blood pressure control significantly. Another question, please.
Fadi Jukaji from Stockholm. Every time we see a presentation for renal denervation, it's recommended to use 6 French introducers, right? I have a question. I know that complications are very rare, but they happen. Maybe a dissection. And it's not very seldom that the artery is 8 millimeters. In case we have a dissection, we'd probably need to stent if it's flow limiting. And having those balloons or stents with this size would be difficult to pull them back into the introducer. You'd have to take everything out. What's your comment on that? Should we consider using bigger size just in case, or this is a too rare happening to even think of?
Well, thank you for the question. I think it's a very, safety is always a very important aspect. So as always, procedure planning will reduce the complications. If you know that there is a very big atherosclerotic plaque, maybe that patient is not the right candidate for the procedure. That being said, in the studies, not all patients had a pre-procedural CT, and the complication rate was below 0.4%. We never had any renal artery stenosis that was induced or dissection where the patient lost a kidney or so. So I don't think we need to escalate necessarily to a 7 French. You could always, take your 6 French out and then bring a 7 French in if you needed to. I do 2 to 3 a month at the moment. We've had extensive experience over 15 years. I think with good planning, there's no reason. The catheter really it tracks really well. It's like a soft balloon. It is not aggressive. So if you respect the fact that you always use your wire first and then your catheter delicately, I don't think that would come as an issue. Maybe
it's actually a good question. Mm-hmm. We were discussing about it already, but it's very, very rare. Mm-hmm. And if you see dissections, you would very likely see them more in the periphery. And there you see smaller vessel diameters, right? And we have seen in the whole set of clinical trials that we oversee with the Spyral system, one dissection in a peripheral, in a distal vessel segment that was ballooned, and that's it. So no stent placed. Very, very safe. It's really a procedure that is safe if you follow the instruction for use.
One last quick question.
Can I ask you a question? Let's say it's less than 45 seconds, and your machine gives this sounding alarm. What's the most common reason? Is it poor contact, or is it inappropriate cooling, or what's the main reason? And then the second thing is, when you said you deactivate 2 of your electrodes, how do you choose between your 4 electrodes which one to deactivate as you go more distally?
Okay, really good question again. Thank you. I could have shown you a picture of the remote, so maybe I'll treat the first question. When you have an ablation that is stopped by the machine within 45 seconds, it's usually a loss of contact in the wall. So for that, you could do a really quick angio and see maybe it's a bifurcation and your electrode is actually at the entrance of a secondary branch, in which case you would just rotate a little bit more the catheter. And then on the remote, there's numbers 1, 2, 3, 4, and they say from distal to proximal. So you can just deactivate the one that have worked and then redo just that white point. And usually torquing 90-degree clockwise or counterclock will solve the problem. If you are in a distal, very small branch, then it will say the temperature has rose too much. And that is where you could give a little bit of nitrates, deactivate 2 or 3, and run them one by one. It's generally a very short segment. So the error message, you will interpret it. The machine will tell you if it's a temperature issue or loss of impedance. And then with your angiogram, you will find the solution very quickly.
Very well. We'll better move on in the program. We now have an opportunity to share or get the experience shared for more than 14 years. So Flavio Ribigini is one of the most experienced interventionists in the context of many things, but also renal denervation. And Flavio will tell us about what he has learned from 14 years of renal denervation experience. Flavio, thank you very much.
Thank you, Marcus, and thank you to Medtronic for this invitation. Well, 2 disclosures before starting. First of all, this is a personal presentation. It's our experience. And the second one, that it took 14 years to fulfill this room. So that means that it was not an easy experience. I mean, just 5 years ago, it was the speakers, the sponsors, and some tired people looking for a chair in the... But now it's full, so we have not been wasting time, and this is a very good sign. Yes, so I will give you 7 points, okay? Resistant hypertension is very rare. Uncontrolled hypertension is very frequent. So we started seeking for resistant patients, and our clinicians taught us that these patients practically does not exist. Because with good medical therapy, with good lifestyle changes, the patients may get into target. But this is not the case for most patients. Ruling out secondary hypertension is important, but you will find very few resistant patients, while you will get a lot of patients that are not on target. And this is the population that we have to look for. Point number 2, the worst patients are those that you will start with. And what do I mean with that? Patients coming to the ward, to the emergency ward and the cardiology ward are the worst, because they are hypertensive. They come because of the consequences of uncontrolled hypertension for a long time, but they have coronary artery disease, heart failure, AFib, peripheral arterial disease, CKD, all that. So you will start working on that unless you make a progress in your team and you involve the patients from others, which are much better. But to get patients from others, you need to organize an open group, open to discussion and to multidisciplinary decision. Don't try to do that in personal meetings. They will never come. They will never come from a building to another. Organize this virtually, and just because of curiosity, they will be attending. And then create the renal denervation saga. Tell them what you are going to do with this patient and how did they do after the treatment. Update on the medical therapy, on the blood pressure, and this will create first curiosity, then enthusiasm, and you will get more uncontrolled patients derived from other colleagues, which are much better than those who came from the emergency room. Among those you will be invited to participate, never forget the nephrologists. They are your closest partners because they have also the worst patients, but probably those that benefit most from renal denervation. These are examples of our own experience in Verona, and there are two important notices. These are patients with advanced CKD. This data has been recently accepted for publication, and what you see is that even patients with CKD have a significant blood pressure reduction at 3 years. And what is even more interesting is that the decline in GFR is less than that expected according to the baseline GFR. So it's a demonstration of efficacy and safety in a totally independent research that has nothing to do with the sponsors of these sessions. Then what we have learned is that we need at least 6 months, ideally more than that, to be effective. This is the data coming from the Medtronic studies with radiofrequency. You see that the blood pressure reduction is incremental after 6 months, after 12 months, and after 3 years. So you have to be patient. And again, this is exactly the same results that we obtained in Verona. This paper has been just accepted for publication. These are patients with normal and impaired renal function. And in all these patients, you see that there is a progression in the reduction of systolic and diastolic blood pressure in 3 years. Due to this incremental effect on time, there is a change on responsiveness, which is one of the questions when we talk to the patients and the referrals. You see that there is an early reduction. Early reduction means less than 10 millimeters of blood pressure systolic or less than 5 in ambulatory blood pressure, or the reduction at least 1 drug in the first 6 months. But then you have the animation of this is not working. No. Okay. But then you have late reductions. You have patients that remain unresponsive, and there are some who had an initial reduction and they do not have a persistent reduction. But globally, after 1 year, you will have nearly 90% of patients having late response. So the percentage of responding is still a moving target, but it's very clear that you have to talk to the patients and the referrer that we need to wait for at least 1 year. And 7, which is specific of this therapy, is an always-on therapy with no side effects. What does this mean? I mean, the blood pressure reduction is totally independent to the patient's behavior and the pharmacokinetics of the drugs. So day and night, Sundays and Mondays, the blood pressure effect is the same after renal denervation. Of course, is very variable with drugs. And the other important thing, and probably for me, from my personal point of view, is the most attractive, is that there is nothing like causing cough, peripheral edema, water retention, erectile dysfunction, and all what happens when you put the patients on polypharmacy therapy. No side effect. I think is the only therapy. I have been go through 35 years of cardiology without known side effects. So put the patient on the lab, try to avoid complications like the vascular complications, do very little contrast not to worsen the renal function, but he will never come back saying that he has to headache or erectile dysfunction or gastric pain because of you. So resistant hypertension is rare, uncontrolled hypertension is frequent. Put this on your mind. I mean, it's two different populations. The worst patients are those you will start with if you start treating the patients admitted to your division of cardiology. Try to get patients from the others, which are much better, probably are just simply hypertensive patients, but do these discussions virtually to start with. Nephrologists, on my experience, are the closest partners, and their patients do benefit from this treatment. Responsiveness is a matter probably of technique, okay, but it changes after time. So be patient, and remember, it's an always-on therapy, and again, it has yet not known side effects. Thank you.
Fantastic. Thank you, Flavio. Now we'll move on to Markus Schlack, who's going to talk to us about the future and what's next for this therapy, and then we'll have our discussion.
Thank you very much. I feel really good. I'm a nephrologist. Did I mention that before? Terrific. So we've heard a lot of important aspects already, and let me just pick up on Flavio's experience. Two things I think are really important, which he mentioned, uncontrolled versus resistant hypertension. One thing I would like to let particularly our interventional colleagues know, there's an almost linear relationship between the number of pills and the frequency of non-adherence. So reducing the pill burden can help with adherence. And of course, we can add more medication, but I think we should think about the alternatives we have. Another important point Flavio made was the efficacy and the safety of using renal denervation in patients with chronic kidney disease. I have been very fortunate to be a part of this journey since the beginning, and the initial discussions were actually around starting this procedure in patients on dialysis. Why? Because we didn't know that this is such a safe procedure at the time. But if you were to perform a procedure which has potentially the capacity to cause renal artery stenosis, to potentially do some damage to the kidneys, it's best done in patients whose kidneys don't work anymore. And we know that patients with CKD have substantial elevation in sympathetic nerve activity, since the diseased kidneys signal via afferent nerves to the brain and kind of perpetuate that cycle of increased sympathetic drive, increased blood pressure, and we have a unique opportunity to interfere with that vicious cycle. In the past, as nephrologists, we have considered actually bilateral renal nephrectomy to improve blood pressure control, and I think we have much more elegant ways of doing that. So talking about what's next, that's certainly on the agenda. And aside from the data we've seen from Flavio already in the context of CKD, the same has been shown now in the global Symplicity registry in a larger number of people. So very reassuring, but at this stage, obviously, we should stick with what the guidelines suggest. Oops, sorry, these are my conflicts. So let me run you through a few things, just where is the field going? Again, huge milestone to have it in the guidelines. Now we can use it, let's use it clinically in the appropriate patient. Let's discuss with the patient what may be the best option for them. Is there still opportunities to optimize the technology? Always. We already heard that transradial or radial approach is certainly something the interventionists are looking forward, and thereby optimizing the RDN technology with next generation catheters, etc., is on the process, but the transradial access is certainly high on the agenda. The generator design is also on the map in terms of improving the experience, but we don't probably expect huge differences there. Expand evidence generation, that's a critical one. We know a lot, but there's still more we would like to know. So the research is ongoing, and keep your eyes open for everything else that comes. And very excitingly, and I'll talk about that in a minute, there's potentially new ablation targets which we could consider. That's the concept of multi-organ denervation. And the reason why this may be very useful is that virtually every organ in the human body is innervated by sympathetic nerves, particularly those organs that play a crucial role in cardiovascular control, such as the kidneys, such as the peripheral vasculature, such as the heart. But other organs which are perhaps more relevant in the context of metabolic control, such as the liver, the pancreas, the duodenum, are interesting organs to consider to apply neuromodulatory therapies that may help us to deal with these complex patients. Let me remind you, if we look at all the data, most of the people who had renal denervation were in the obese range. Very frequently they had diabetes. A lot of them are at high risk. So obviously we want to improve blood pressure, but wouldn't we want to target the other risk factors as well? And neuromodulation may well offer an opportunity in this context. So this is just some insights into what is coming in terms of the transradial approach. A longer catheter obviously required. The interventionists are very familiar with these while maintaining the excellent performance and deliverability, which has been demonstrated by the Symplicity Spyral system. Of course, continue to leverage from the excellent safety profile that has been established, and there won't be the need for any capital equipment required in the context of new generators. They can continue to be used. Now, in terms of evidence generation, Medtronic did a terrific job in kind of maintaining a registry. And while obviously registries are not necessarily considered the highest or the most robust level of evidence, I think they're critical. It's the real world. It's really what happens to our patients who are not in an artificial clinical trial. And that registry continues to give us indications, give us ideas about the safety and the efficacy, and particularly in the long term. And hypertension management is a marathon. It's not a sprint. What we're trying to achieve is long-term, durable blood pressure reduction. And this has been shown, particularly in the GSR Define registry. There's the Spyral Affirm registry, which looks at more specific population to, again, increase the evidence and our experience. And this is still ongoing and will be presented at the various meetings. Now, very exciting in the context of what I mentioned earlier, the concept of multi-organ denervation. Spyral Gemini is just upon us, so we will start very shortly with this protocol, which includes simultaneous denervation of both kidneys and the liver, not simultaneous, but in the same session with the same kind of catheter approach, and that is to hopefully further improve the blood pressure reduction, but also have some beneficial impact on the metabolic aspect of those patients. And we've seen this slide before. We know, of course, there's significant blood pressure reduction, which certainly will result in improved outcomes based on the evidence we have. But again, can we do more? And particularly in the long term, can that be enhanced? And perhaps with multi-organ denervation, targeting the sympathetic drive even more may be useful in this context. I've made that point before that sympathetic outflow to various organs is a critical component in mediating what we consider cardiovascular risk, and the hepatic outflow is critical in this context, both from a cardiovascular and regulatory, but also from a metabolic aspect. It's a very good rationale why we should do this. And in this slide, you see what is anticipated to be done, targeting the common hepatic artery. So this is arising from the celiac trunk, which then gives rise to the splenic artery. And it is the common hepatic artery from there on until the gastroduodenalis branches off. And that's the target we would like to go for in order to further enhance the efficacy. This is just a schematic of how the vasculature looks. Certainly, perhaps not the vasculature interventional cardiologists are used to, but from the experience of interventional radiologists, it doesn't seem to be a very tricky area. And very nice data, some of them presented today in earlier meetings, illustrate that there's even more abundant nerves around the common hepatic artery. They tend to be bigger. So again, it seems that may be a very fruitful target going down the line, and hopefully we'll have soon some data. This is just comparing the renal artery versus the common hepatic artery. You see not huge differences in terms of the average vessel diameter, so the current catheter should work very well. The algorithm will be slightly different. Same issues, but we would assume that the same principles apply for hepatic denervation as they do for renal denervation, which I'm sure a lot of you have some experience already. This is what it looks like in a swine model. You see the catheter here in the right, left renal artery, and in the common hepatic artery. And you see also in terms of the dimension, the diameter, not much of a difference there. We've published also some years ago some preclinical evidence highlighting two things. One, that it is safe to do. We did not have any issues regarding the liver, and importantly, it was shown that there's a significant reduction in the norepinephrine content in the organs that are being denervated, and you see both for the kidney at 7 and 28 days and for the liver substantial reductions, not 100%, but very consistent, and that's probably the Symplicity catheter that allows us to achieve this circumferential ablation pattern and therefore get a good reduction in blood pressure and coverage of the nerves that are present. So this is this Spyral Gemini pilot trial, which will run 2 cohorts. It's really a safety and feasibility trial, not necessarily powered to look at endpoints in terms of blood pressure. Obviously, we will look at those. One cohort, not dissimilar to what was done in the Spyral off trial, people with elevated or uncontrolled hypertension without major cardiovascular risk, and in parallel to that, a separate group that has increased cardiovascular risk, including type 2 diabetes and or obesity. And we will see how the combined renal and hepatic denervation will perform in these instances. This is the procedure and the follow-up. I won't spend much time on this. We will do the renal arteries first and then move into the common hepatic artery. So the only difference to what is currently done is probably a bit more time, obviously required to ablate a third vasculature, but that should be the only difference. So Spyral is something we're very much looking forward, moving the field ahead, and we'll be excited to show you some data as soon as that is available. Also would like to remind people that Medtronic is still open for investigator-initiated or external research to be considered. So if you have any thoughts, ideas, certainly happy to look at those and see what we can do in order to further advance the knowledge in this field. And these are just some examples that have happened in the past and gives us further insights in where to go. So I better stop there, and thank you all for being here and for your attention. Thank you.
Thank you very much. Marcus, perhaps you can join the panel and then we have about 7 minutes for discussion. Please come and use the mics and ask questions. So we have some questions from the audience, and I knew this question always comes up, but today I feel we've tried to answer a lot of it in our presentation. So Flavio, we are getting the question again around patients with renal impairment, what your GFR cutoff is, how comfortable you are. You showed us some of this data already, but perhaps you could come to that again.
Well, as I said, the population can be that of patients under dialysis. So actually, you have nothing to lose. I mean, their renal function is gone, and the only variable that you have to check is the suitability of the vessel's diameter to accept the devices. Small vessels are very infrequent unless the patient is under dialysis for a very, very long time. So no concern about treating patients on dialysis. Of course, a lot of concern when you give contrast media to patients with impaired GFR. So dilution of the contrast media, reduction to the minimum possible, avoiding check controls, looking for spasms after ablation makes no sense. You just give nitro at the end of the procedure and you use the contrast media. No other concerns.
Fantastic. So the next question from the audience, maybe I can pose, if it's all right, to Felix. Someone has talked about, how much you're doing this procedure, and they kind of wanted us to each on the panel talk about it. But, in an average month in your centre, how often are you doing it? What have you noticed in terms of trends?
I think we're all seeing a pickup in numbers at sites. I recently moved a year ago, so we're just starting our program again, and we're doing round about 30 to 50 procedures a year now. So that's roughly one patient per week.
And maybe, Valerie, you could talk to the same.
So I don't think the rough numbers might be very relevant because it, of course, relates to how big your center is. But what I can say is that the activity has doubled since the guidelines were implemented. So it was also concomitant by our hypertension clinic being very successful in providing a service to the GPs and the cardiologist for all the secondary hypertension workup. And as this provided a good service, the physician built trust with us, and the activity and the referrals for RDN have doubled to almost triple, I think, by the end of the year, thanks to that. So it's a combination of hypertension clinic, the guidelines, and the safety of the procedure being demonstrated with the success over time.
That's fantastic. Thank you. And so there's a perfect question for Marcus here that's around, what do you think the mechanism of action is around hepatic artery denervation?
Well, again, what we've done with renal denervation, which was, again, a huge advancement, obviously, is to very selectively and specifically target the renal nerves. And this is why we don't see many side effects, as Flavio has shown. In the past, before we had renal denervation or very successful drugs, when surgeons performed a procedure called splanchnicectomy, that caused a lot of trouble because they also severed the nerves that supply the lower extremities, for example. And these patients had trouble standing up. So it's really precision medicine in a sense. It's selectively targeting the renal nerves. In a talk earlier today, Felix mentioned that I think transplantation is always a good example. If you transplant a kidney, if you transplant a liver, you sever all the nerves before you then implant that into the recipient. And if there's no rejection, the organ works perfectly well. So these nerves are not essential for the proper function of the organ. Of course, they have a role to play, but in our environment, that is probably negligible. And again, the data we have shows that it's very, very safe. So targeting yet another kind of vascular outflow certainly makes sense in the context of the huge interaction we see between, for example, the kidney, the liver. You're perhaps familiar with the hepatorenal reflexes. So there's volume aspects that come in. There's obviously inflammation and other aspects that come in. And it will be very interesting to see, particularly in the long term, how combined denervation will hopefully result in more even more pronounced blood pressure lowering and potentially in improving the metabolic profile, which is usually significantly altered in most of the patients we consider for renal denervation.
Brilliant, thank you. So then there's another technical, we have a lot of technical questions, which is fantastic. It means I think there are many people in the audience who are starting this procedure. There's a question around someone who's already got a renal artery stent. Is it an absolute contraindication? Would you ablate distally?
Those patients have not been systematically excluded from all of the randomized trials, so there is experience with priorly stented renal arteries. We have done some preclinical work that was published almost 11 years ago now, 2014. And it's very safe to ablate distal to the stent or proximal to the stent. And the margin should be, 5 millimeter distance between the stent, the stented area, and your ablation spot. Then it's safe.
Fantastic. So I think we've still got more questions, but the session is coming to a close. I think everyone can agree it's been a fantastic session with loads of audience participation, so we appreciate that. And many of the speakers will still be around for a couple of minutes if you still want to ask some more questions. So thank you very much for attending. Thank you very much to the panelists.